All right, everyone. We will call this session to order. Thank you for joining us for our oral abstract session on clinical CKD and glomerular disease. If you haven't already, you probably heard this at every session, but please download the mobile app, the NKF mobile app. You can get your pre-test, post-tests, and evaluations done here while you're on site, and that's done for your CME. Presentation slides are available for most talks on the app and in the portal based on faculty permissions. Please share and discuss your experience at NKF on social media with hashtag NKFClinicals, and consider joining the National Kidney Foundation as your professional home. Without further ado, we are going to jump right into our abstracts. Our first abstract will be presented by Dr. Dana Risk. Dr. Dana Risk is a tenured professor of medicine in the Division of Nephrology at the University of Alabama at Birmingham. She also serves as Director of Clinical Trials Research in the Division of Nephrology and Associate Dean for Clinical Trials Research at the Heersink School of Medicine at UAB. She has a passion for education and is a recipient of several teaching awards. Her clinical and research interests revolve around glomerular disease, in particular IgA nephropathy. So we welcome her to speak about her oral abstract.
Thank you so much, and thank you for the kind introduction and the invitation to share with you today post-hoc analysis from the phase 3 visionary trial looking at sibeprenlimab in IgA nephropathy. Here are my disclosures. I do serve on the steering committee for the visionary trial. I'm the co-chair, so that's, I think, the most important disclosure to keep in mind. So we really wanted to do two objectives with this post-hoc analysis. One is to evaluate the treatment response of sibeprenlimab across different proteinuria thresholds, particularly aligning with the KDIGO recommendation that recognizes proteinuria reduction as a key marker of improved kidney outcomes. And as a quick reminder, the KDIGO guidelines suggest a proteinuria of less than 0.5 gram per day as, optimal, and then, outstanding, or I guess, the aspirational would be to drop that to less than 0.3 gram per day. And to use the response rates of proteinuria targets to calculate the number needed to treat, which helps determine the clinical benefit of treatment with sibeprenlimab. So just a quick reminder, IgA nephropathy is the most common glomerular nephritis worldwide. It's often diagnosed in young adults that are between the age of 20 and 40, and a substantial portion of patients will progress to end-stage kidney disease within 10 to 15 years of diagnosis. And as I mentioned, the treatment guidelines based on the updated KDIGO really target a proteinuria reduction of less than 0.5 gram per day and ideally less than 0.3 grams per day as key treatment targets. So sibeprenlimab is a humanized IgG2 monoclonal antibody that selectively blocks APRIL, therefore preventing or reducing the production of pathogenic galactose-deficient IgA1. That's the first hit in the 4-hit disease pathogenesis. Normally, the galactose-deficient IgA1 levels are elevated in patients. There are autoantibodies formed against the galactose-deficient IgA1, leading to circulating immune complexes that ultimately sit in the kidneys and lead to damage and loss of kidney function. So the visionary trial was a phase 3 global trial that enrolled patients with biopsy-proven IgA nephropathy they were adults. They had to have persistent proteinuria of more than 0.75 gram per gram or more than 1 gram per day on a 24-hour urine collection. eGFR had to be relatively preserved, more than 30 milliliter per minute, and they had to be on stable doses of RAS inhibition, ACE or ARB. And they could be on SGLT2 inhibitor, but again, they had to be on stable doses for at least 3 months before study entry. They were then randomized to receive sibeprenlimab 400 milligrams subcutaneously Q4 weeks versus placebo. And patients were stratified based on their proteinuria at entry, eGFR at entry, more or less than 45 milliliter per minute, and SGLT2 inhibitor use, yes or no. And as you probably know, the primary endpoint was change in UPCR at 9 months compared to baseline. And key secondary endpoint are the slope, annualized slope of eGFR. We don't have that data yet. and then some other secondary endpoints like safety, change in serum IgA, IgG, IgM, and then some exploratory endpoints that are listed here, including change in hematuria and serum galactose-deficient IgA1 and APRIL levels. So at the time of the interim analysis, we had 320 patients that were analyzed out of the 510 entire cohort. There was a predominance of men, just like we see in this disease in general. A good representation of Asian population, about 60%. The mean age at study entry was 42.8 years, and the mean UPCR based on a 24-hour collection was 1.54 gram per gram. The drug was well tolerated and led to a significant reduction in the treatment arm of 50.2% in proteinuria compared to an increase in proteinuria in the placebo group of 2.1%, resulting in a placebo-adjusted treatment effect of 51.2% at month 9. And that was the primary endpoint that led to the accelerated approval of sibeprenlimab, or as we now call it, Voyxact, by the US FDA in November of 2025. When we continued to follow these patients at 12 months, now the proteinuria reduction was further, 56.6% compared to baseline versus placebo. So again, a 54.3% relative or placebo-adjusted treatment effect. So this post-hoc analysis evaluated categorical proteinuria response rates using, again, the interim data that we had at month 9 and month 12. And then we calculated the number needed to treat to achieve this proteinuria threshold. So here are the results. You can see that sibeprenlimab produced significantly high response rates when compared to placebo. So you can, on the x-axis, so on your left-hand side, let's see, does that work? Maybe, yeah. This is 9 months, and this is 12 months. And you can see that, if you use less than 0.3 gram per day, less than 0.5 gram per day, and less than 1 gram per day as thresholds, all of these are in favor of the treatment arm, which is shown in the green bars. But you can see that, of course, as the threshold is, as you look for higher bars, the number of patients that are able to achieve that threshold, of course, goes down. But really, the number needed to treat is not too high. So you need 9 patients, 6 and 4 patients respectively, to get these thresholds of less than 0.3, less than 0.5, and less than 1 gram per day. If you wait until month 12, these numbers get even better. So for every 7 patients, 5 or 4 patients that you treat, you will have 1 patient that will achieve one of those 3 thresholds that are set. And again, the 1 gram per day used to be the old threshold, and now the bar is much higher. If you look at a percent change in proteinuria, and again, using somewhat arbitrary proteinuria reduction cutoff of 30% or more, 40% or more, and 50% or more, you can see, again, on your left-hand side is the month 9 data. On your right-hand side, the month 12 data. The longer you wait, the more patients achieve these milestones. And again, the higher the bar or the achievement, of course, less patients go to more than 50% and so on and so forth. But the number needed to treat is relatively modest. So you need 3 patients to have 1 patient achieve any of those 3 bars. And then if you go to month 12, you need 2 patients. So for every 2 patients treated, you get 1 additional treatment response, which is quite remarkable. So in conclusion, in this post-hoc analysis of the phase 3 visionary interim analysis, sibeprenlimab led to significantly high response rate across all categorical proteinuria targets at month 9, but also that was maintained at month 12. Proteinuria targets included either absolute values of less than 0.3, less than 0.5, and less than 1 gram per day, or percent changes of 30% or more, 40% or more, 50% or more reduction in 24-hour UPCR and 24-hour urine protein excretion. The number needed to treat values ranged from 2 to 9 individuals, depending on what outcome you're interested in, and generally trended downwards with time. So the longer you wait, the more patients achieve these metrics. And nearly 1/3 of patients receiving sibeprenlimab achieved a urine protein of less than 0.5 gram per day at month 12, aligning with the evolving KDIGO treatment goals and providing clinically meaningful measures of support treatment decision-making in IgA nephropathy. The low number needed to treat values and the consistent benefit across all proteinuria thresholds reinforces the clinically meaningful efficacy of sibeprenlimab in IgA nephropathy. And as a reminder, the Visionary trial is ongoing. We continue to evaluate the safety and efficacy of sibeprenlimab in patients, and we're awaiting eagerly, I would say, the eGFR over 24 months treatment period that hopefully we will get before the end of this year. And with that, I'm happy to take any questions. Thank you.
If you have a question for this abstract, please come to the mic. And maybe while we're waiting for people to come to the mic, you just comment, you know, the number needed to treat is a really helpful metric, and we sometimes balance it with the number needed to harm. Do you have a sense of what the trade-off looks like with treatment in terms of the side effect profile?
That's a great question. We did not look at the number needed to harm, but in general, the safety has been pretty good, and we have not had any significant, severe adverse event. The adverse events were quite balanced between treatment and placebo group.
Great, great. Any other questions for Dr. Buzik? Come to the mic, please, so everyone can hear you. Thanks.
Did we look at the GFR, how it's affecting the GFR?
The GFR data is not available yet. It's blinded.
Okay. Sure.
And I'm blinded to the data as well, so can't answer that.
Any anti-drug reactions, like unable to tolerate the drug, or sibeprenlimab, or discontinuations regarding to antibodies to sibeprenlimab?
So there were antibodies, anti-drug antibodies is what you're asking for, and some of them were neutralizing antibodies, but these did not seem to affect the efficacy of sibeprenlimab, so patients still had the proteinuria reduction, so they were not clinically significant.
So the drug was continued?
Yes.
That's good. Okay, thank you. Thank you so much.
Thank you.
Oh.
So I actually have more of a clinical question. So because, you have new medications coming out for IgA pretty much like, I can't keep up. So what is your approach? Like if you have a patient, let's say, who was diagnosed before Sibi was, approved, and I have treated the patient with, let's say, Tarpeo, or they're on sparsentan. So what is your usual approach? Because that's not I guess that's technically not the phenotype studied here, right? Like a patient is already received steroids in some way, shape, or form, and they have been on sparsentan. So how do you approach this patient now? Now I have this new drug, and seemingly is doing great. So how do you approach that?
That's a great question. So the standard of care continues to evolve. So people that are on supportive care, endothelin inhibitor, dual endothelin inhibitor, SGLT2 inhibitor, as new trials are coming on board, you can see that the number of patients on these background therapies has increased. And most of the trials are allowing patients on sparsentan or atrasentan to come in as long as they've been on a stable dose where you think at least the hemodynamic effect is, you're past the point of hemodynamic effect. So that should not stop you from escalating therapy if your patient is not doing well. The other thing I would say is that these trials did not prevent people that had been previously treated from entering the trials either. So there was a washout period. You could not have been on steroid or Tarpeo 2 weeks ago and then came into the study. But systemic steroids had been used, and some of the patients that were enrolled had been on steroids before but continued to have severe disease as evidenced by their high level of proteinuria, and they were treated. And there was, if your patient is doing well and has resolution of proteinuria or very little proteinuria, you may not want to escalate therapy. But if they're still not doing well, there's, in my opinion, nothing that would prevent you from treating them with some of the newer agents.
Okay, and along the same lines, do you have like a preference now for APRIL-BAMF inhibitors versus complement inhibitors? Like, how do you make that decision? Is there any biopsy features that would make you choose one over the other, or any patient-related factors?
Nothing that has emerged from these trials yet. The biopsy data will be coming, so most of these agents are having dedicated biopsy studies that would have biopsies at the time of data of the study entry and post that would then help us hopefully identify biopsy features if there are any that predict response to treatment. We don't have that, and all the entry criteria, as you probably know, have been similar. So, and we don't have the GFR data for all of these drugs, so it's really hard to compare between them. But with time, I think we will learn how to use them and which ones to prioritize. But we need more data.
Okay, thank you.
Thank you.
Our next speaker is Dr. Jensen Hall. Dr. Hall is an assistant professor of medicine and nephrology at Duke University School of Medicine and director of the GlomCon Foundation, HBCU Outreach and Workforce Development Collaborative. He received his MD and PhD degrees at the University of Maryland, at Baltimore School of Medicine, and completed his internal medicine residency and nephrology fellowship at Duke. He's currently faculty at the Duke Molecular Physiology Institute, where his lab focuses on the genetics of inherited kidney disease with special focus on FSGS. Dr. Hall.
All right. Thank you, everyone, for coming to this session. And I'm going to be presenting on our work with the Embark Awareness Program. A little bit different than my usual sort of molecular talk, but I think there's still a lot here that's very important. Helps us to think about how to care for patients better. Okay, these are my disclosures. So the learning objectives, we're going to review current challenges to patient and community education in nephrology, consider the Embark Awareness Initiative as a novel model for connecting patients and providers efficiently, and consider the critical roles of mentoring and workforce development in advancing kidney health awareness. So just a review of the challenges that we face, and this is by no means a comprehensive list, but certainly relevant to the scope of this discussion. So in the environment that we practice, a few things are true. There is a disproportionate risk of CKD and ESRD among Black, African American patients and their families, people that are just medically underserved. We understand this. We know this to be a trend that we can attribute in many respects to some genetic links that we'll discuss. There's an accelerating need for patients to be their own advocates and to be aware and up on certain elements of data that normally they wouldn't have been responsible for in order to be their own advocates and to position themselves properly in the care discussions. And the automated environment that they have to exercise this new skill set in is also evolving and complex. There's a growing influence of non-traditional information sources. That is my euphemism for stuff online. And I spent a good amount of time debunking myths that come at you at a certain pace. I think the newest one is a certain oil that you can get that cures all kidney disease. But you don't really think about it, but there's a fair amount of time that we spend dealing with questions in those categories. There are tightening resources available for not only physician education, but research training. And this is suffocating and is getting worse, and not just at my institution, but across the board. So we have to really think about the investments that we're going to do here and ways that are going to endure, hopefully, beyond the period of constriction. Also, current trends and projections for declining minority physician population, which is really important because as we understand more about certain diseases with a genetic basis that affect disproportionately people of minority and diasporic backgrounds, we want to be very conscious about not only the people that we're caring for, but who we're positioning to take over our roles as physicians in the current day for the needs that will come in the future. So what does this challenge require? Well, it requires some really obvious things like enhanced patient and family education. We really need to talk to patients in more informed ways about their disease process, about what we understand about it, in ways that they can understand and communicate to their family members. Because of some of these conditions having a more clear basis in genetics, we need those discussions at home to carry forward, and we need those to be accurate and well-informed. Enhanced physician education, believe it or not, thinking about the fact that, you know, many of us trained with mentors and teachers who more or less for most of their career existed and practiced in a desert. They didn't have the opportunities that we have now. So maybe their reflexes for taking care of certain things, considering certain disease processes is different. And so we have to take into account that a new way of educating physicians, particularly those exiting training, is necessary. We need community-based and industry partnerships because of the new funding landscape. We need to come together as a society with all of these resources available to us to partner and make new opportunities available so that the research and the efforts to train can be sustained and even grow over the long term. And of course, workforce development, a particular passion of mine. I'll discuss programs that we're supporting through GlomCon. But again, another opportunity to think about how we can serve our patients, not just with their needs in the present day, but what we can do for them going forward. So our approach to addressing some of these concerns was through the Embark Awareness Program. Our three-point mission in Embark is one, to increase kidney disease awareness for patients, for families, even for physicians, to provide screenings for kidney disease, and this is not just for APOL1, but for chronic kidney disease in general, and to participate in research for kidney disease, so registry development, walking alongside other organizations that are actively pursuing certain areas of research interest. This way, we think that these alignments can help us to better support the needs of the patients and to kind of register throughout time going forward. This is sort of a schematic of how our screenings run, and this is just so that you can kind of get a visual sense of what we do. Obviously, this is set up like most screenings are set up, but there is sort of a novel component that I'll clue you into as we go. So patients come in and they register. In any environment where we set up to do one of these screenings, whether it's traditional house of faith or whether it's on a college campus, we will set up these tables, registration first. Patients will then get blood pressure and BMI checked, urinalysis with urine dipstick. Usually for qualifying patients, and what I mean by qualifying is if you have 1+ proteinuria or above, you're from a certain demographic background, African American or recent African ancestry. You can then move on to the waiting area as all that data is assembled and passed over to a nephrologist who is on site for these screening events. And this is the innovation. We want to put nephrologists in conversation with potential patients in the moment that these findings are being uncovered. Most patients don't know that these things are happening, particularly on college campuses. Many of the students that have proteinuria have no context for knowing this. And so not only do you want to tell them about the finding, but you want to give them a context for understanding it. That's why a nephrologist is brought to these conversations. We also have these nephrologists selected from the local area so that if follow-up for genetic testing needs to happen, that the patient and the provider are not separated by distance. The patient can then follow up months later, weeks later, in the clinic where they saw the nephrologist that offered them the genetic testing and have a more fulsome discussion. If they qualify and genetic testing is offered, then that conversation is the first of probably many that the participant and the provider will have on this topic. And then there's sort of an outgoing sort of disposition where we kind of assemble their data, offer them some closing educational literature, and make arrangements for them to meet again with the nephrologist for the review of genetic testing results if they get them. We are supported in this effort by partnership with Vertex Pharmaceuticals and Natera, who offer us the Renasight panel and that testing for free. Occasionally, we'll use Arcana, APOL1 genetic testing, but all of this is no cost to the patient, even counseling services that come after the fact. In the inaugural year, this is what we were able to accomplish with this model. We visited 8 cities and performed 15 screening events. We are really looking at events like this to establish new partners in nephrology. So if your area of practice kind of aligns with an area where we might be doing a screening, we would love to have you join us, be the nephrologist that's offering the consultations on site, also following up patients as needed. At this time, our network was just developing. It's expanded since then. We have many more interactions that have taken place, and the numbers of patients screened and tested has increased as well. What you can see is that 648 patients in the first year were screened for kidney disease. 258 were ultimately genetically tested. I'm showing you these pictures on the right because you can see the cross in the background. We're doing it the way that people usually do it in houses of faith. Those partnerships are critically important. They're institutions that have a certain credibility in communities and allow for patients to enter these scenarios, particularly patients that come from backgrounds where trust is an issue, with more confidence and faith that the testing is going to be done in a way that is appropriate and fair. And we also do our best to make sure that each of these events is supported by the sort of the proprietors of the institution that we're using. We want the venues and the collaborations to be connected so that they can endure and we can revisit some of these sites and create a lasting impression. So a little bit about the roles of Embark faculty. I already invited you to kind of join with us. Here's the website where you can visit and sort of just register as a potential volunteer. We really want to grow this physician network. It's very important that physicians and patients connect early. If you've ever been in a nephrology clinic and have seen patients coming in late stages of chronic kidney disease and you've gone beyond the point where there's certain things, even in the standard of care, that you can do to help them, it's very frustrating. So the earlier we can see patients, the better we can do for them, more options we can offer. Your role as a physician would be not only to attend the screening events, but we have pre-formed data that are pre-formed educational presentations for you to present. There is some ongoing effort right now to kind of fine-tune them a bit depending on the audience. Obviously, college students don't need to hear as much about, diabetes management and hypertension as maybe some of the older cohorts that attend our events might. But we want to make sure that education is valuable and appropriate for everyone that comes. And so that's part of what you would do. You're not responsible for creating the content, but just delivering it, and we will provide that for you. The on-site nephrology consultation is a key element in this, and we want you to be able not only to speak to participants in the moment, but be willing and able to accept them into your clinic. We want patients to be able to attach kind of in that moment. And then also to provide them with information about clinical trial opportunities and so on. So who else should actually carry this message? I just invited physicians, but there may be some other messengers that are helpful. So it depends, in my view, on what the disease looks like. If you're considering AMKD, we know that some of these presentations can be very early on, maybe second, third decade of life, is when these kids will develop these problems that then can carry forward and create serious issues for them later in life. I use the slide that I'm showing you as part of an informational session that I present to students who I'm looking to recruit to some of our mentoring efforts. This is the first of those, the mentored internship program in nephrology. This is a program that we developed in collaboration with Duke University initially, where we bring students to campus from HBCUs, have them embed in a lab for a year to do research with the investigators. They receive mentoring, clinical shadowing exposure, just a really valuable and enriching experience for them. We make this available because we realize that opportunities like this are not necessarily as available for them as with others. And we want to make sure that this talent pool does not get missed in consideration for ultimate professional contribution to nephrology. We also created or established a new program just this past semester, which we piloted at Xavier University in Louisiana, so right up the road, I see it in the back, and also at the College of William and Mary. We are going out to these campuses to get kids to speak to each other about kidney disease. My daughter, who is 22, as of yesterday, confirmed for me that I am no longer cool enough to speak to people in her age group. And so we need people like her that are comfortable with not only language, but how they communicate, their modes of discussion, to engage each other on these topics. These are some pictures of very happy and engaged and participatory young people that did us a great service in our inaugural semester. So from all of this, what can you say? There's a growing need for us to educate, and how we do it, I think, really does matter. There are ways to bring all these efforts together. We can educate and inform, we can screen, and we can mentor, all in the same effort. We just have to think about ways that people receive information and how we can educate them to disseminate our information in creative ways. Embark, I think, represents a good effort, one that sort of presents a multimodal strategy of culturally informed patient education, provider access, and trainee learning opportunities that are brought together in ways that are very impactful. So I encourage you to join us. You've seen the URLs that you can join and see more about us. And then also there's posters G5, 15, and 16 later today in the poster session. Come talk to me about it. We have more time. All right, thank you very much.
Thank you very much, Dr. Hall. And I will invite people to speak with Dr. Hall after the session or at the poster session just for time. Thank you. Our next speaker is Dr. Oba Reverie. She is a research program coordinator at the Johns Hopkins School of Nursing, where she oversees a multinational hypertension control trial operating across Ghana and Nigeria. She's a physician and epidemiologist holding a Doctor of Medicine from Kharkiv National Medical University and a Master of Public Health in Epidemiology and Biostats from the Johns Hopkins Bloomberg School of Public Health. Thank you very much for joining us.
Hi, everyone. Thank you for that warm introduction. So I'm presenting on behalf of the TRIVE pilot trial. I'll present the impact of food as medicine intervention on urinary sodium and potassium, amongst other things. So this work is funded by the American Heart Association's Healthcare by Food Initiative. I have no conflict of interest to disclose. So our learning objectives is I am going to describe the disparities in hypertension burden among Black and Hispanic adults and the rationale for using food as medicine interventions in healthy food priority areas, and also explain the TRIVE Food as Medicine trial and the intervention components. And I'll also be summarizing the effects, the TRIVE effects on blood pressure, DASH diet quality, and the urinary biomarkers. So as a way of introduction, we all know hypertension is the #1 modifiable risk factor for cardiovascular disease and chronic kidney disease, which affects 1 in 2 adults in the United States. The highest prevalence is seen in the Black adults, about 59%, and Hispanic adults are also having compounding barriers, which is food insecurity, limited insurance, and also gaps in culturally concordant care. So the healthy food priority areas are areas where they are food insecure and they have limited access to groceries or healthy food. And this is mostly where we see hypertensive Black and Hispanic adults. So in order to address these gaps, we're using the food as medicine, which we know is scarce in these healthy food priority areas, and we know this works. The TRIVE trial, before we began the trial, we did a human-centered design in order to, with community members, Black and Hispanic, just to get a sense of how we're going to tailor the diet, our produce prescription to this community to make it culturally adaptive. So this is where we got the TRIVE Food as Medicine intervention. So our intervention components, the enhanced Usual care received the standard produce bags and also linkage to social services. And the tribe intervention received dietitian coaching and produce prescription. And also, we also had adaptive bidirectional text messages. And we had pharmacy, or they had the option of home delivery of their produce, which included recipe cards on how to prepare this produce. They also had access to linkage to social services. So our tribe study design, this was a 24-week two-arm randomized pilot trial, and we enrolled from 8 community sites, which include churches, food distribution centers, community hubs, and also clinics, and these were all centered within LD food priority areas in Maryland. And the eligibility criteria for this was uncontrolled blood pressure, self-identified participant, Black or Hispanic, and we also, our primary outcome was DASH adherence, secondary outcome was reduction in systolic blood pressure, and also urinary and serum electrolytes. Our sample size was 80 participants. The characteristics of the tribe participants, among the 80 participants that we enrolled, the mean age was 54 years, and 57% were females, and 62% were Black African American, the rest were Hispanics. Their baseline cardiovascular risks at enrollment, 76% had hypertension stages 1 and 2, and 90% were overweight or obese, and they had a mean A1C of 5.8%. So notably, like almost 90% were foreign-born, were immigrants, and this is very important in understanding culturally appropriate food produces for them, to tailor it to their culture and their background. And this is also a high-risk group because most of them had stage 1 or stage 2 hypertension. So the social drivers for this, our participants, 36% were food insecure, and about 70% had an household income less than $50K per year, and about 31% had no health insurance. The baseline DASH score were 3.8, so 50% were below the 4.5 mark. So our outcomes, like I said, our primary outcome was change in DASH diet, and from this graph, we can see that at baseline, they all started below 3.8, like I said, which is like less than 4.5 for the standard DASH diet. And at 12 weeks, the control had an increase in their DASH diet score, but it actually dropped, it attenuated at 24 weeks. But the intervention, the Thrive group, had a steady increase in their DASH scores. So we can see that they had, at the end of 24 weeks, they had 4.1 in their DASH score. This is also the mean change in the DASH score. The tribe participant had higher at 24 weeks, and within the group change of 0.78 compared to 0.25 in the enhanced usual care. So there was also an increase in the LD eating index, which was increased by 11 points in the Thrive group. The blood pressure at baseline they both started, the Thrive and the control both started with a blood pressure of about 137, systolic blood pressure of about 137, 138 millimeter mercury, but the Thrive intervention had a drop at 12 weeks and also maintained that at 24 weeks. The control group had a slight drop in their systolic blood pressure, and that was still also maintained in 24 weeks. At 24 weeks, change in systolic blood pressure from their baseline. This is amongst the people that had high DASH diets in the DASH groups. So we had the low and we had the high. So for this, we stratified by baseline DASH adherence, and participants in the Thrive arm who started with higher DASH scores, about 4.5 and above, they experienced a drop in their systolic blood pressure of about 13.3 milliliter mercury at 24 weeks, which is statistically significant. And in the enhanced group, the same group showed a 2.0 millimeter mercury in their systolic blood pressure. So this threshold sensitivity analysis confirmed a dose-response pattern, and the higher the baseline dietary readiness, the greater the blood pressure benefits from the Thrive group. So the urinary biomarkers. So this is the urinary sodium-potassium ratio, which is a sensitive biomarker of dietary sodium to potassium balance, and it is associated with blood pressure and cardiovascular risk. At 12 weeks, the Thrive showed a within-group change of 0.40, and the control showed 0.60. And the between the group difference was minus 0.20, which is not significant at 12 weeks. And also at 24 weeks, the Thrive group also showed a drop of 0.20, and the control had an increase of 10. So the difference was about minus 0.30, while the between group differences were not statistically significant. The Thrive group trended downward, but all the values remained within normal physiological changes. So our key findings, sorry, I went a bit too far. Our key findings for this was that in the I-diets category, the Thrive group had a significant drop in the systolic blood pressure of about 13.3, and those that had a DASH diet of more than 4.5 just showed that they were ready. They had dietary readiness, which predicts a good response to an improvement in their systolic blood pressure. And there was also a dietary quality improvement in the Thrive group. And we also had an increase in potassium excretion, urinary potassium, and also urinary sodium, but the sodium and potassium ratio remained the same. In conclusion, we say these results support implementation of a fully powered randomized controlled trial, and this study was feasible and acceptable, and just shows that DASH readiness is a key moderator of blood pressure response and inform future translocation. Potential policy case for integrating food is medicine into cardiovascular prevention programs. Thank you. Any questions?
We have time for just one or two questions. If anyone has one, let's come to the mic. So you obviously, this is a pilot, and so you looked at some stratified analyses in exploratory way. So your interpretation that those with the higher DASH score at baseline had DASH readiness. Could you speak a little more about that and what you think DASH readiness, how that could be measured in your full trial?
So when we say DASH readiness, DASH adherence is basically like when we're going to prescribe this produce, are they going to adhere to the diet? So that's what we mean by DASH readiness. Most of them had a score of about 4.5. Those that more than 4.5, we could see that they adhered to the DASH diet, which now showed an improvement in their systolic blood pressure.
And with more access to
yes, more access to food.
vegetables,
Yes.
And what's the maximum, just to give people context, what's the DASH score range?
So it's ranged to 9. It's from 0 to 9.
Thank you. Any other questions? Thank you so much.
Thank you.
And our final speaker in this session is Dr. Susan Wong. Dr. Wong is an associate professor of medicine in the Division of Nephrology at the University of Washington and an investigator at the Kidney Research Institute and a nephrologist and bioethics consultant and core investigator at the VA Puget Sound Healthcare System. Dr. Wong leads patient-oriented health services research program on dialysis practices and end-of-life care among patients with advanced kidney disease. Her goal is to create more patient-centered models of care. Thank you very much.
Can you hear me okay? Thank you for sticking around this afternoon. I'm delighted to share with you the results of an ethnographic study that I did as part of a Fulbright Award to study models of conservative kidney management in the United Kingdom. Before I begin, I just want to acknowledge the generous funding from the Fulbright Commission and the Global Innovation Fund for this work. I also received research funding from these organizations. That said, I don't have any conflicts of interest. And today I'm going to talk about some key differences in the context in which conservative kidney management operates in the US and in the UK. I'm going to talk about the strengths of models of conservative management in the United Kingdom, and then point out some considerations with trying to adopt those models in the UK for implementation in the US. So just to make sure we're all on the same page, conservative management is a holistic, planned, and proactive approach to caring for patients with stage 4 or 5 kidney disease who have made the choice to forgo dialysis. And the emphasis of care is on providing kidney supportive care to optimize quality of life and comfort. There have been several systematic reviews done so far showing that patients can survive months to several years after their decision. They can enjoy stable quality of life through to the end of their illness, and they have a more comfortable end-of-life experience. They more often receive hospice care and less often die in the hospital setting as compared to patients on dialysis. And though conservative management is endorsed by our clinical practice guidelines and our professional societies, it's still relatively uncommon for patients in this country to not be treated with dialysis. And so this is a graph that shows you the rates of patients forgoing dialysis who have a GFR less than 15 in health systems in the US. Light blue is Providence Health, yellow is the VA, and health systems in other countries. The UK is in green, and Australia in dark blue. And you can see that it's pretty uncommon for patients in the United States to forgo dialysis. And why this is the case, it's very multifactorial, but one glaring reason is that we don't have the same clinical infrastructure to provide high-quality conservative management as compared to these other health settings. So if there's not the infrastructure, how can patients make this choice? In contrast, the United Kingdom is a world's leader in providing conservative management. These are the results of a famous study called the CKD study that described conservative management services across the country. And in the 71 renal units in the UK, they found that the majority provided dedicated conservative management pathway, had dedicated staff to support this pathway. Some had dedicated funding for this pathway and clinical guidelines to support best practices. Many also provided home care services to extend their reach beyond clinics and medical centers. And with all of this robust infrastructure in place, programs on average cared for about 45 patients on the conservative management pathway. So with this map of conservative management in mind, I set out for the UK to understand what are the key features of their models of conservative kidney management that we might be able to bring to the United States. So I conducted an ethnographic study of 5 exemplar models of conservative management in the UK, and these are illustrated by the red stars on this map. And these models were selected based on consultation with the CKD MAPS investigators, as well as programs that served diverse populations in geographic regions. Ethnography is an immersive approach to a qualitative inquiry. And so if you can imagine conservative management as a complex intervention, then traditional methods like survey design, as the CKD MAP study did, or structured data with administrative claims, can only reveal the tip of the iceberg in terms of what conservative management is, so costs, outcomes, things like that. But there's so much more that goes into effective care delivery or an effective complex intervention. And those things include institutional cultures, policies, care interactions, care processes. And these are more obscured and live underneath the surface and best illuminated with ethnographic methods. So what did we find? The programs I observed had a mean longevity of about 13 years, and programs all had nephrology consultants and clinical nurse specialists, but varied in terms of whether or not they had palliative care specialists and geriatricians on the team. And the average caseload of these pathways were about 72 patients. I completed over 95 hours of observation of these programs of both clinical and non-clinical activities, interviewed 30 clinicians and staff, and reviewed 41 unique documents produced by these programs. And what all of this qualitative data showed were that there were 3 key essential features of conservative management programs in the UK. The first is that these conservative management programs were embedded in a broader specialty model of kidney failure preparation. The second was that conservative management, its education, decision-making around it, care, were all centered in patients' homes. And the third is that the programs used a shared care model where consultants and nurses work together as a team to co-manage patients. And I'll talk about each theme in more detail. So what was remarkable about these programs was that preparing for kidney failure was regarded as a subspecialty in nephrology, the same way that glomerular nephritis or onconephrology were regarded as subspecialties within nephrology. And so when patients reached a GFR of 20 or 15, they would transfer out of their usual nephrology clinic into a specialty clinic that prepared them for kidney failure and the end-of-life transition, with the rationale being that the nephrologist who diagnosed you and worked so hard to prevent your progression of kidney disease isn't necessarily the best person to prepare you for kidney failure and the end-of-life transition. And so it's a little bit like you don't want your kindergarten teacher to also be your senior high school teacher. These are really different skill sets. And so the skill sets that their colleagues recognize that the providers had in these specialty conservative management, specialty preparation clinics was that they were very skilled in serious illness communication and advanced care planning. Their colleagues also appreciated that these providers took a holistic approach to the patient as opposed to a more disease-based or biomechanistic approach to their kidney disease. A second key feature of these conservative management programs is that education, decision-making, care were all centered in patients' homes. And this meant that nurses and consultants traveled to patients' homes to have these difficult discussions about their options and which option suited them best. As patients progressed in their illness, care then moved from the clinic into patients' homes where labs were drawn, medications were delivered, care was delivered to patients in their home. And so with this design, it was very clear for patients and providers alike that conservative management was a home-based treatment modality for kidney failure as compared to dialysis or pre-dialysis care, which was centered in the clinics or in medical centers. And then finally, a third important feature of these conservative management programs were that consultants and nurses adopted a shared cared approach and worked as a team to co-manage patients. And so consultants and nurses huddled frequently to ensure a cohesiveness in terms of, or a shared understanding of a patient's values, goals, and wishes. And so these teams would huddle frequently. They would huddle before clinic, after clinic, once a week, once a month, to make sure that there was a cohesiveness in the care plan. It also created a sense of mutual accountability that all providers were providing the best patient-centered care they could for the person. Okay, so these programs were doing an amazing job. What can we bring to the U.S.? Well, I think if we did adopt some of these models for the U.S., we'd need to consider pretty striking differences between the U.S. and the U.K. context. The first is that there are major differences between these two countries in terms of our attitudes towards decision making. So in these UK programs I observed, there was a very proactive and intensive approach to decision making and education. Whereas in the US, we have more of this slipshod approach where patients can decide not to decide, or even if patients decide about conservative management, they'll just change their mind at the 11th hour anyway when they get sick. We also tend to delegate our education away to dialysis organizations, which will obviously provide a skewed presentation of the kidney failure options. Another important distinction between the US and the UK context is our approach to the patient-provider relationship. So in the UK, these programs comprise multiple providers who work together, huddling frequently to ensure cohesiveness and consensus in decision-making and planning. But in the US, through qualitative studies, we know that there's a lot more care fragmentation here. And there's more concerns from nephrologists that even if a patient decides conservative management, they can't guarantee that that patient won't get started on dialysis if they're seen by another provider or in another health system. Here, there's also the perception that the nephrology provider should be the same person from beginning to end of a patient's kidney journey. And while there are a lot of pros to this approach, I don't think we also recognize the cons to this kind of continuity in the relationship. And then finally, the last major distinction between the UK and the US context is that in the UK, they've really created an infrastructure for home-based care, and this is extremely rare to find in the US. Here, care is primarily provided through hospitals and clinics, and this is true for not only all aspects of kidney care, but also end-of-life care, where the majority of our patients die in the hospital setting. And so here, the organization of care is really around the efficiency and convenience of providers and health systems than really for patients. There's some limitations to this study. The first is that I only observed 5 programs, and so these findings may not be generalizable to all the conservative management programs in the UK. I also observed the programs for 1 year, and so findings may not represent practices in the year before, in the time before this year or the time after. I also only collected perspectives from providers and staff, and I did not collect corroboratory information from patients and families in these programs. And I was the only observer of these programs, and so all the data is filtered through my lens. So in conclusion, the US and the UK face very different contexts within which conservative management exists. UK models are embedded within a specialty model of kidney failure preparation, are centered in patients' homes, and rely on a team-based shared care approach. And so implementing similar models in the US would require substantial cultural and infrastructure change in this country. So thank you for your attention. Thank you to the other speakers for their excellent talks today, and to the many collaborators and supporters of this work. Happy to answer questions.
Please go to the mic with your questions. Thank you.
It's just a comment here that is so I know when I came to this country, we were talking dialysis, this, that, and all, everything. But then slowly we changed and started talking about end-of-life care. And I know in ASN, we had the geriatric nephrology pre-course, and I attended that. Then we started talking about the palliative care. Mm-hmm. And yes, there are institutions, they have palliative care, and I was in Wisconsin for 15 years, and we had the palliative care team to help us out, even if the patient agrees for dialysis, but they do round in the dialysis unit, and they had the team, the nurse, who would do the home visit and all those things. So that way we were able to emphasize. So they didn't have to continue dialysis. They could stay at home, and their symptoms, other things are taken care. And yes, as of now, I have few patients, but the place where I am, there's no palliative care team. Mm-hmm. So I do most of the thing there. And I do have 4 or 5 patients whom CKD stage 5, I'm still helping them with the help of the local, the hospice team, but they as a comfort care, not the end of life type. So in that way, we are doing that. But I understand that more and more nephrologists has to accept this, because I do see there are a few of my colleagues, they have very difficult time to explain to the patient when they know in their heart that nothing is going to help. And dialysis is not the option, but they have difficulty in explaining that to the patient. Mm-hmm. Yeah. So those things are more here. So I think the palliative care team, that those groups, even the nephrologists can become palliative care specialists also. Mm-hmm. And if we improve that program, that will help.
Yeah. Thank you so much for your reflections. And you hit on so many good points. And I just want to reiterate them. First, you talked about the changing landscape of the patients we're treating who are approaching kidney failure. They're not like the patients that we were seeing 20 years ago. They're much older. They have a lot more comorbidity. Their prognosis on dialysis is wildly different than it was 20 years ago. And we need to upskill our geriatric and palliative medicine skills. Where if you happen to be practicing in a place where you have access to palliative care specialists, absolutely reach out to your colleagues. You don't have to do this in isolation. They are an incredible resource. But if you don't have that, then create those allies in primary care with your community hospice, because they can be hugely supportive and really help to carry the load of this. I think the other, and this is where I have to thank you for stepping up, is that we can also gain these skills. I think primary palliative care skills is a job that for all nephrologists. We can all learn these skills. These are going to be helpful, whether it be conservative management or withdrawing dialysis or working with anybody in the ICU to have these skills. So I invite all of you to really step up to the challenge of learning these skills. And there are wonderful resources at the ASN that's to get this training, and also at the ISN as well.
Yes, thank you for your comparative talk. I always find it interesting to hear the differences between the American approach versus NHS in England, or even the Canadian approach. But I guess my question to you, and perhaps the previous questioner would have insight into this as well, and that is, I wonder how you factor in, or if you factor in at all, governmental priorities, I guess, perhaps putting it all together like that. The NHS and CMS have different leadership structures. It's always been my understanding NHS is a far more resource-limited organization than CMS, and what the society accepts perhaps is different. And I'm wondering to what extent priorities that are handed down from the governmental regulators affect physicians or patients' decision-making and their freedom of decision-making.
Mm-hmm, mm-hmm. I think that's such an important point, that government has a hand in developing policies and reimbursement structures that incentivize patient-centered care. And right now, we don't really have that, unfortunately, whether it be dialysis care or conservative management. And I think those are things that yes, our lawmakers, those creating policy, needs to enact, to kind of speak more broadly. But I completely agree. I think this change is not, right now in the U.S., this change, the emergence of conservative management is grassroots. It's coming from the patients and providers saying that we need other options. And I think it's time for government also to respond and say, hey, how can we create the infrastructure? How can we create the reimbursement structures to support this care?
If you would allow me to just add one thing to the questioning. To push the point, I actually had a different thought in mind, and that is top-down influencing as a bad thing, potentially, was really what I was getting at. And I do understand your point that we need more understanding of palliative care, the whole understanding of euthanasia, for example, I see in this country as potentially being a part of that. But my question is, where it is possible, if you think this is the case, where top-down can be damaging to patient freedom? To what extent does government priority of cost saving, for example, which I believe is a greater impetus in NHS rather than CMS, and to what extent, not necessarily in terms of the individuals perhaps you were observing, but to what extent does that culture impose itself on physicians and their likelihood of proposing a less expensive, if it is less expensive, and less intense medical interventional medical as an approach for the patient.
Yeah. And we can probably talk more offline, because I am watching the clock, but I think to answer your question more briefly is that one hope, The dangers of top-down is when the government does not represent their constituents. But I think if governments are representing their constituents, then they should be enacting policies that don't seem coercive, restrictive, or it feels like rationing, too. So we'll talk more offline. Thank you for those important questions.
Let's thank our speakers for a really exciting set of abstracts across a wide range of topics. Thank you so much.